This is a discussion of our new report that was just released titled Taking Action Against Clinician Burnout, a Systems Approach to Professional Well-Being. This report is now available and it can be downloaded as a free PDF along with other related materials at nam.edu/clinician wellbeing study. The slides from today, as well as a recording of this event, will be available at that URL in the coming days. And you can also follow the conversation about the report in this event on social media at #AgainstClinicanBurnout. For those of you who are not familiar with our study process, to give you a little bit of background, for each requested study, panel members are chosen for their expertise and experience, and they serve pro bono to carry out the study's statement of task. The reports that result from the study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. We have here with us 6 members of the committee to discuss the report. We'll first start off with opening remarks from National Academy of Medicine President Victor Zhao, and then the committee members will give an overview of the report, and then we'll open it up for Q&A. Those of you who are in the room with us are asked to go to the aisle microphone over here, and if you wish to ask a question. Those of you who are watching the webcast should send in your questions to supportingclinicianwellbeing@nas.edu. Again, that is supportingclinicianwellbeing@nas.edu. We ask that you identify yourself and your affiliation when you're asking a question. And with that, let me introduce Dr. Victor Zhao, President of the National Academy of Medicine, who will give brief remarks.
Good morning. Good morning to all of you. Thank you. I'm Victor Zhao, and I'm so pleased to welcome you to this public report release event. And the report is called Taking Action Against Burnout, a System Approach to Clinician Wellbeing. So our nation is facing an epidemic of clinician burnout. Last several years, the medical community has recognized an alarming crisis of physician burnout and suicide, although the public remains largely unaware of it. So it is in the interest of assuring quality of patient care and well-being of our clinicians that today's report is released to shine a spotlight on the crisis and recommend solutions to prevent it. Now, the epidemic of burnout affects both those in training as well as those in practice. Over 50% of physicians and 45 to 60% of medical students and residents have symptoms of burnout. Furthermore, physician rates of depression or suicidal ideation remains very high as 40%. This issue is not unique to physicians. There are high prevalence rates of symptoms of post-traumatic stress disorder, emotional exhaustion among nurses, and many other health professionals. The trend is alarming itself, but even more so when we consider the impact of patients and society. Burnout has been linked to self-reported errors, patient dissatisfaction, a reduced ability to express empathy. Burnout may result in increased familial problems, stress-related illnesses, automobile accidents, and substance abuse. Clinician burnout is a threat to patient quality care. So these facts are really disturbing, and we must act urgently to reverse these trends. Not on my script, and I'll tell you 2 stories. When I was a resident back in Boston, I had an all-night. I actually was a senior resident. I sent one of the junior residents home so that he can get some sleep because he's on 2 nights in a row. When I drove home, my car went off the road. And before I can even wake up to it, I saw myself hitting a fence and ran to someone's backyard. Thank God no one was hurt. And that's when you have tiredness and burnout. And I really thought of leaving the residency. And I think Derek heard me talk about that before. The second issue is that I always say if physicians are burnout or clinicians, can you imagine that you go to an airplane and the pilot says, I'm burnt out? So that, I think, emphasizes how important it is to address this issue, because it is also not only about the clinician's well-being, but also the patient's well-being. Now, it has been said that personality traits of clinicians, that is high-achieving, hard-working, caring, predispose them to burnout. These qualities, coupled with concern for stigma, appearance of weakness, and fear of vulnerability, the so-called culture of silence, have kept clinicians from acknowledging the problem and seeking help. As the committee will discuss, burnout is not due to weakness of the individual or problem of mental health. The heart of the problem lies with demands in the work environment and added pressures of external factors such as policies and regulations. The rapid changes in the practice of healthcare over the past several years, including mergers, consolidations, increased patient demand, introduction of electronic health record, extensive documentations, changes in reimbursement, changes in regulation by government insurance, have resulted in a very large demanded workload, high productivity expectation, and more time spent on administrative tasks. As a result, clinicians have less time to interact with their patients and also with each other, their colleagues, let alone to attend to their personal lives. As the healthcare community recognizes this problem, many hospitals, medical centers, training programs have sprung to action. Many have different interventions, programs of wellness, and others have developed. But many of these actions are done in isolation and not through coordination. So until recently, there's been no collective effort to study and document the outcomes of the various activities. So there's a real need to solve this problem together, systematically, to research what works and what doesn't scale, and scale the successful one to a national level. This is how we got involved. The National Academy of Medicine, as an effective convener, has brought to the table organizations that are developing solutions with many stakeholders, policymakers, insurers, educators, health system leaders, and health information technology experts. We launched the Action Collaborative on Clinician Wellbeing and Resilience, and that involved a network of more than 200 organizations working on this. Although the collaborative had been quite successful, it became very clear in the collaborative there's more work to be done, and that a consensus study would further elevate this issue to national and international importance and lead to meaningful change, which is why we're here today. We're so pleased that we're able to convene and commission a consensus study to evaluate the available evidence on clinician burnout and well-being and make recommendations for change. You hear this outstanding committee, and I thank them, and we'll have a chance to thank them personally, have done work of over 18 months and look at evidence, review and deliberated on the evidence, and develop recommendations on designing systems to reduce burnout and foster professional well-being. I think you see that this resulting report is a bold vision for redesigning clinical systems, one that focuses on activities that patients find important to their care and enables and empowers clinicians to provide high-quality care. So once again, I want to thank this fantastic committee and, of course, our staff for the outstanding work. They put long hours to tackling this topic, and I think that I'm sure that we'll see the efforts not only reflecting the report, but impacting our society altogether. One last word. You know, we believe that consensus study and reports have such influence because, as you know, in the National Academies, consensus report influenced the trajectory, in this case of health, and by instigating policy changes in organizations, government, etc. Nearly 20 years ago, the Institute of Medicine, the precursor organization of the NAM, launched the modern patient safety movement with publication of 2 landmark reports, To Err is Human and Crossing Quality Chasm. And these 2 reports, too, call out the real important issue of a crisis and actually provided solutions that have really transformed patient care. We are confident that this report will have a similar report for the field, calling attention to safety, health, and well-being of our clinicians, and of course, the quality of our patient care. So I'm going to end by saying that we recognize the recommendation report must be translated to action. As you hear shortly, we built a robust communication plan, and for the report, an action collaborative will also advance many of the recommendations. So once again, thank you. I do want to particularly call out and thank the co-chairs, Pascal Caron, who's here, thank you, and of course Chris Castle, who actually will join us, I believe, electronically. So they will take it from there. Thank you very much for being here.
Thank you, Dr. Zhao. And now I'm going to turn it over to the members of the committee who are here with us in person and virtually. We have Pascal Caron, who is the Leon and Elizabeth Jansen Professor and Director of the Wisconsin Institute for Healthcare Systems Engineering at the University of Wisconsin-Madison. Joining us on Zoom, we have Christine Castle, who is our co-chair, along with Dr. Caron. She is Senior Advisor on Strategy and Policy and Professor of Medicine at the University of California, San Francisco. M. Lynn Krisman, who is Dean and the James T. Deluso Regents Chair and Barron Centennial Professor at the University of Texas at Austin College of Pharmacy. Lottie Derby, who is Professor of Medicine and Medical Education and Co-Director of the Program on Physician Wellbeing at Mayo Clinic. Sharon Pappas, Chief Nurse Executive at Emory Healthcare. And Vindell Washington, Chief Medical Officer at Blue Cross and Blue Shield of Louisiana. And with that, I'll turn it over to you.
Thank you very much, Stephanie, and thank you to all of you for being here with us. We also thank the people who are on webcast. See if I can manage the... Excuse me. So like Dr. Zhao said, about 20 years ago, 2 landmark reports were issued by the Institute of Medicine that really launched a number of transformative activities across healthcare to address patient safety and quality of care. Our report, Taking Action Against Clinician Burnout, a systems approach to professional well-being, is a critical follow-up to both of these major reports. We are calling attention to the safety, health, and professional well-being of all healthcare clinicians. We believe that delivering safe, patient-centered, high-quality, and high-value healthcare requires a clinical workforce that is functioning at the highest level. The Board on Healthcare Services at the National Academies of Sciences, Engineering, and Medicine undertook this consensus study to look at clinician burnout, its consequences, and its causes at the request of the National Academy of Medicine's Action Collaborative on Clinician Wellbeing and Resilience. As you can see on that slide, the study received generous support from many sponsors who are committed to improving clinician well-being. The committee was comprised of 17 members that represented different disciplines: healthcare quality and patient safety, burnout research and implementation sciences, different clinical disciplines, healthcare administration, policy, law, and financing, healthcare quality and medical ethics, and human factors and systems engineering. I want to thank all of the committee members, and in particular my co-chair, Chris Castle, for the amazing work that we have accomplished over the past year. The committee was charged with a study to look at the evidence on burnout and its consequences for both clinicians and patients, to look at the components of the work environment as well as the training environment that can contribute to burnout, to try to identify a range of interventions, tools, and approaches to support clinician well-being, and finally to propose a research agenda to improve the knowledge base. The process of the committee aligns with processes at the National Academies for Consensus Studies. We met in person at 4 separate meetings. We had multiple conference calls between October of 2018 and this year in August of 2019. 2 of those meetings were public information gathering sessions. We did a very extensive review of the literature, looking at about 4,000 articles and different reports. The recommendations were driven by the evidence in our literature review, as well as all the different inputs we received at multiple meetings. And the recommendations were driven by consensus. The process finally included an external peer review by 14 experts in different disciplines related to the study. Clinician burnout is a phenomenon that is very much anchored in the workplace. The World Health Organization has defined burnout as being associated with what they call chronic workplace stress. Like Dr. Zhao mentioned, this is not a mental health diagnosis. Burnout is actually composed of 3 different dimensions: emotional exhaustion, depersonalization or cynicism, and a low sense of personal accomplishment. Because burnout is anchored in the way work is organized and care processes are designed, we looked at the chronic imbalance between high job demands and low job resources as major factors that contribute to burnout. I will go through a more detailed description of those job demands and inadequate job resources later on, but think about workload as, or high time pressure as being part of high job demands, misalignment of professional and personal values as being inadequate job resources. Between 35% and 54% of nurses and clinicians, so that is up to 50% of nurses and physicians, experience high levels of burnout symptoms. Like Dr. Zhao said, between 45 and 60% of medical residents and students also experience burnout, significant burnout symptoms. This is a major problem. Unfortunately, the literature that we reviewed did not include systematic data on other clinicians, such as pharmacists and dentists, but there is a little bit of evidence here and there that tells us that burnout is also a problem across all clinicians and all clinical professions. Our review of the literature and the evidence shows that burnout has a lot of negative consequences for clinicians, and Dr. Zhao mentioned his personal experience with accidents, or I guess near accident, as a consequence of burnout. Our review of literature identified other negative consequences, for instance, for patients. Problems in communication between patients and their clinicians, patient safety incidents. Other consequences that we identified are experienced by healthcare organizations that, as a result of clinician burnout, may see clinicians intending to leave or even leaving the organization, or in some cases leaving the profession. Which of course has dramatic consequences for all of us and for society, as clinicians are highly trained professionals, and when they experience burnout and want to leave the profession, this is a loss for all of us. It is also pretty clear in our report that clinician burnout is very complex. and that there is not one solution. There are multiple factors in the work environment, what we call work system factors, that contribute to burnout. Therefore, a systems approach is warranted. This is the way that we can not only understand burnout and the factors that contribute to burnout, but also identify solutions, and solutions or interventions at all levels of system. So looking at just one element of the system or one level, whether it's the external environment, healthcare organization, or frontline care delivery is not enough. And that's the essence of that systems approach, to understand the specific job demands and job resources experienced not only by clinicians in their work environment, but also by learners in their learning environment. We want to engage with all of you in a bold vision of really taking action against burnout and figuring out how we can redesign systems so that clinicians can do what they have been trained to do, to provide high quality and safe care, and also to ensure that patients are receiving that high quality, safe, and high value care. We are encouraging different members of the system, whether it's healthcare organizations or members of the external environment, to figure out how to target those known system factors that impact clinician burnout, as well as professional well-being. This is not easy. Those systems interventions are going to require deep commitment, infrastructure, resources, and accountability, as well as a culture that supports clinician well-being. Because of our systems approach, the committee decided, also based on our task statement, the study charge, to develop a conceptual model that can help all of the stakeholders in the different levels and pieces of the system to take action. Our conceptual model is anchored in a number of theories and models and disciplines, for instance, job and organizational design, occupational safety and health, as well as human factors and systems engineering. And the model is inclusive of all clinicians, those that are in the work environment as well as the learners. This is the committee's system model of clinician burnout and professional well-being. It articulates the different system levels that contribute to work system factors. And those work system factors are really the core contributing factors that affect clinician burnout and professional well-being. There are three levels of the system that our conceptual model talks about. The frontline care delivery, so this is where the care team, the clinicians, physicians, nurses, other clinicians, and patients and caregivers interact. The healthcare organization that makes a lot of decisions about how to organize delivery of care and care processes, as well as the external environment that influences all of the other system levels and is influenced back by the frontline care delivery level and the healthcare organization level. So think about the three circles as being very much interacting and influenced by each other. When the work system factors are inadequate, that is when there are high job demands and low job resources, then clinician burnout occurs and professional well-being is negatively affected. And of course, there are individual mediating factors that are in between the work system factors and clinician burnout. I talked about the consequences of burnout on patients, clinicians, healthcare organizations, and society. And then information can then be used as a feedback loop to really transform systems at different levels and use that information on burnout and its work system factors in a continuous improvement feedback loop. So let me talk a little bit about the work system factors. This is a major component of our system models. Think about job demands as workload, high time pressure, and you may recognize some of them as things that many of us experience. There are also very unique job demands that are unique to clinician's job, administrative burden, workflow, distractions, and interruptions that negatively affect clinicians and may contribute to burnout. Inadequate technology design, technologies that are not usable, not useful, that creates frustrations and potentially burnout. And moral distress, really the misalignment between what clinicians want to do, what they think they should do as responsible professional clinicians, and what they're asked to do, or what they feel they're asked to do, whether by healthcare organizations or by patients. The job resources side also includes many factors that are anchored in the work system, in the design of the system. For instance, organizational culture that are not supportive, that do not provide what clinicians need to do to provide high-quality, safe care. Limited autonomy or job control, or professional relationships and social support that may be inadequate or may be negative. Again, these things could contribute to clinician burnout. So it's really the imbalance between the high job demands and the low job resources that can create clinician burnout. Our model also identifies individual factors such as personalities, coping strategies, and resilience. And those are unique to each individual and mediate the effects of the work system factors, that is, the job demands in balance with the job resources on clinician burnout and professional well-being. As our committee looked at the literature, in particular looking at specific interventions, the committee concluded that there was a need to provide a set of guidelines for healthcare organizations to move forward with addressing clinician burnout and to really figure out how can we target those work system factors that contribute to clinician burnout. The guidelines for designing well-being systems are organized around 3 areas: values, systems approach and leadership, work system redesign, and implementation. In the first group of guidelines, you would not be surprised to see, of course, the systems approach as part of the guidelines to really help organizations, healthcare organizations, understand that there are many different elements of that system, whether they are technology design and implementation, where they could be the physical environment, the way people work together, and so looking at all of these different parts of the system. Of course, healthcare organizations have to figure out how to align their structures and processes with their values. And misalignment of values is an important contributing factor to burnout. So aligning their values as well as the values of their clinicians with the way they're organized and the way they function. And finally, leadership. And we're talking about leadership at all levels of healthcare organizations, the top governing boards, but also leadership at the unit or the department level. Engagement and commitment of leadership is really critical to engage in that difficult effort of designing and implementing well-being systems. The second group of guidelines is about work system redesign. So that gets at the core of what clinicians' job should be about. Clinicians should not be spending time on low-value activities. They should be spending time on activities that have meaning and a purpose and contribute to patient care, what they've been trained for. Adequate resources in terms of workload and technologies, physical environment, should also be provided to clinicians. And finally, in the area of work system redesign, we call attention to team-based care and figuring out how do we design systems that help with team collaboration, communication, as well as professionalism. The third group of guidelines has to do with implementation. Implementation of well-being system is going to require an infrastructure that really supports the efforts of redesigning systems in different parts of the system. That would include resources, processes, structures, and again, that continuous improvement. This is not an easy process. There is not one single solution. And figuring out how do we implement interventions, evaluate them, and then create those feedback loops that Dr. Zhao was talking about, of also disseminating what works. Making sure that the organizational culture really supports those activities. Just want to call attention to one element of psychological safety. So creating an environment where clinicians feel safe, psychologically safe, to talk about burnout and its contributing factors. And finally, using human-centered design approaches and tools to figure out how to design good solutions that are good for clinicians as well as patients. Clinician burnout is complex and multifaceted problems. There is no single solution to achieve the changes that are needed. Therefore, we recommend a collective and coordinated action across all levels of the healthcare system, frontline care delivery, healthcare organization, and the external environment. And this is what our recommendations that are organized in 6 goals call attention to. I will now pass on the microphone to my colleague, Sharon Pappas, who's going to talk about Goal 1, creating a positive work environment. Sharon?
Thank you, Pascal. And so this is the part where it's what you've all been waiting for, to find out what are our recommendations. And we've grouped them around these goals, and I'll begin, and the rest of my colleagues will pick up the rest of the goals. Goal number 1 is around creating positive work environments. The detail behind that is that we believe healthcare organizations are responsible for creating and maintaining positive work environments that clinicians find to be safe, healthy, and supportive, and that foster ethical and meaningful practice. We also believe healthcare organizations can enable the delivery of high-value healthcare by addressing burnout and its impact on the safety, the health, the job satisfaction of their clinical workforce. These guidelines that Pascal just referenced, we used as our principles by which the redesign of a work system can occur. To get into a little more detail from here, I'd like to talk about some of the specific recommendations that relate to what healthcare systems can do. The first being develop, pilot, implement, and evaluate organization-wide initiatives to reduce the risk of burnout, to foster professional well-being and enhance patient care. Specifically, we believe that healthcare organizations should commit their board and their leadership to improve the clinical work environment. We understand that creating and maintaining a C-suite level leadership role and function responsible for professional well-being across the organization is an important step. Healthcare organizations should design interventions to align with the organizational values such as respect, justice, ethical practice, compassion, and diversity. Healthcare organizations should assess how business practices and management decisions affect the work environment, specifically the job demands and the job resources. And then also in this section, we believe that holding all leaders responsible for improving the work environment within their scope of responsibility. The second one you see here on this list, that healthcare organizations should adopt and apply principles that improve the work environment and balance job demands and job resources. The first in that category is that the committee provides evidence-based guidelines in this report that support high-functioning systems and healthy work environments. The principles are a blueprint for creating a positive work environment. The Magnet Program for Nursing is an example of a program that reflects these principles. And then finally, routinely measure clinician burnout and ameliorate the work system factors that erode professional well-being. The specifics behind that recommendation are that healthcare systems should use validated measurement tools to assess burnout and the contributory factors relevant to their system. Healthcare organizations should use these data to capture strategies that minimize burden, protect privacy, and mitigate stigma or pressure that clinicians may perceive. Healthcare organizations should also assess total workload and the complexity of the work expected of clinicians, including things like continuing education requirements, maintenance of certification, and required institutional learning modules and work performed outside of scheduled hours. Healthcare organizations should maintain clinician and patient input to identify and eliminate documentation and other administrative burdens that are not mandatory and that contribute little or no value to patient care. Healthcare organizations should report on professional well-being of the organization's clinicians and the outcomes of their interventions, at least annually, overseen by the governing boards. And then finally, healthcare organizations should use these data to guide system-oriented efforts and continuously learn and improve processes of patient care. I'll now ask my colleague, Lynn Chrisman, to go over Goal 2.
Goal 2 focuses on creating positive learning environments for learners and looking at learners at all levels in health professions degree programs as well as postgraduate training programs such as residencies and fellowships. Much like healthcare organizations, educational institutions, their affiliated training sites, accreditors, and related organizations are responsible for creating and maintaining positive learning environments that support the development and well-being of students and trainees. The committee recommends that educational institutions work together with healthcare organizations to ensure that efforts to prevent and reduce burnout are coordinated across the work and the learning environments. The committee reports that health professions, educational institutions, and clinical training sites should develop, pilot, implement, and evaluate initiatives to improve the learning environment and support learner professional well-being. This has to start with the top of the organization, with executive and board leadership committed to the improvement of the learning environment and providing the resources and holding educational leadership accountable. There must be a designated leadership role and function responsible for improving and sustaining learner professional well-being across the organization and across the continuum of learners. The committee recommends the creation of systems of learner evaluation that fairly evaluate competencies while mitigating undue stress and promoting a collaborative learning environment, including criterion-based grading and a consideration of pass-fail grading. The committee recommends that resources and culture that promote and support personal and professional well-being and help-seeking be provided. When we look at a positive learning environment, we have to look at the faculty as well as the student learners. We must provide the appropriate development of faculty so that in a positive environment so they can be the positive role models for learners. Clinical faculty are involved in patient care, they're involved in teaching, and they're still expected to produce research and scholarship, and we must look at reasonable workload balances for clinician faculty. The committee recommends routinely assessing the learning environment and the factors that erode professional well-being and contribute to learner burnout. This includes using validated measurement tools to assess burnout and the contributory factors relevant to their system, and to assess the clinical and academic workload expected of learners, including preparation for licensure exam, other high-stakes examination, and required institutional and professional learning activities with the goal of achieving a reasonable workload that is sustainable over time. The committee recommends reporting on professional well-being of learners and intervention outcomes be done at a minimum of annually and overseen by the leadership of the health professions education institution. Barriers must be removed to student-learner participation in well-being assessments, including protecting learners' privacy and mitigating stigma or pressure that learners may perceive. And we must use data to guide systems-oriented efforts to prevent and reduce learner burnout and improve professional well-being. lastly, the committee recommends that accreditors, regulators, national educational organizations, health professions, educational institutions, and other related external entities partner to support the professional well-being and the development of learners. There must be a commitment to improving the learning environment at the highest level of administration at both the university as well as in the clinical teaching organizations, that is the hospitals and clinics where our students and trainees learn to provide care. The committee recommends that to reduce the risk of learner burnout and optimize learner professional well-being, these entities should commit to identifying, implementing, and evaluating strategies that optimize learner professional well-being and development and support the discovery and implementation of evidence-based approaches. Accreditors and administrators of licensure and certifying exams should evaluate how their policies affect learner professional well-being and willingness to seek emotional support. The committee recommends that leadership be engaged and committed at all levels to curbing learner educational debt with such strategies as improving access to scholarships and affordable loans and building new loan repayment systems. With that, I'll pass it on to Devinda Washington, which will move on to goal number 3.
Thanks, Lynn. The third goal really is focused on addressing the negative consequences on clinicians' professional well-being that stem from the laws, regulations, policies, and standards that are really fostered and promulgated by the group that was in that first external environment. Thank you.
Thanks.
The environment that was described by Pascal earlier, and that environment really was talking about external entities, including federal government agencies, state agencies, local agencies, professional organizations, and accreditors. There are many requirements regarding health care delivery that place burdens on clinicians. These are policies that include payment policies, clinical documentation policies, quality measurements, reporting, prescription drug monitoring policies, and the like. And the idea here is that each of those have some potential downstream negative effect on clinician well-being if not addressed appropriately. It was and probably is imperative to note that the committee in almost all cases thought that these requirements were not put forward out of malice and actually responded to a need and were well-intentioned. But the combined burden sometimes created barriers to positive patient care experiences and contributed generally to the risk of burnout among providers. On to specific recommendations. There are many healthcare regulatory agencies at different levels as discussed in the external environment, many at the federal level like CMS, the Office of the National Coordinator, National Quality Foundation, state legislatures, professional boards, departments of health. Our recommendation is that all those organizations allocate the necessary resources to support assessment of the effects of those regulations, policies, and standards on clinicians in the various settings, and that this assessment be a formal assessment conducted both prior to and post-implementation of those regulations, policies, and standards, and that appropriate modifications be made over the course of time as indicated by the outcomes. Also, that we should apply human-centered design and human factors, systems, engineering approaches in developing those standards and regulations and policies in the first place, and wherever possible, align licensure standards and enable broad license reciprocity for all clinicians required by states. The second portion of our recommendation is around payers and healthcare organizations and promoting and the development and the use of technology to streamline the documentation that's necessary for their quality reporting, billing, with the goal of decreasing the overall clinician workload. One description we use in the committee is to say that those documentation elements should be provided in the course of normal care, and that any additional work required to generate those documents should be balanced as you evaluate their importance. The fourth goal that we underscored as a committee started with a recognition, and that recognition is that technology offers both solutions and challenges in this healthcare space. There are problems that we had noted with the usefulness and quality of healthcare IT tools. Sometimes they are poorly integrated into clinical workflow. There's still sometimes difficulty in sharing information among clinical team members, in each of the settings that they practice, and some limitations in this construct of clinical decision support, which is not currently at the level that we think it should be as a committee. We did recognize as a committee that there are some early efforts in many of these areas, but we think that those technologies still require an excessively challenging amount of time to use and sometimes have difficulty, which should be addressed as part of our recommendation. We specifically recommended strategies where vendors, clinicians, healthcare organizations, regulators, policymakers in this broader external environment work together. One of our notes was that often those operations do not have the right amount of integration, so the integration of new technologies and approaches was sort of an overarching goal where these entities work together in the development of the technology itself. In the way of specific recommendations, the committee recommended that regulators use human factors usability and safety criteria to evaluate and certify health IT. That health IT vendors, healthcare organizations should design and configure systems to improve the clinical work environment, including attention to the cognitive workload and workflows that reduce the demand of clinical documentation and automate essential tasks. Again, in short, documentation in this sort is a byproduct of the care delivery system and does not require its own external workflow. Healthcare IT vendors, healthcare organizations, and regulators should closely monitor implemented technology for these negative consequences and should have an existing mitigation plan in place to address. The last technology recommendations really center around information flow. Our recommendation is that health information should be shared efficiently, safely, and securely across electronic health records, electronic pharmacy records, digital health applications, medical devices, and quality data repositories. We also recommend that the entire team have access and appropriate access to the data that's necessary to care for folks, and that information should be present and flow in a timely and accurate way to foster the care delivery that our citizens of the country deserve. Again, a major goal should be allow to clinicians to focus on optimizing patient care and population health, while the adjuvant processes and technologies drive, to the extent possible, the essential business and administrative and research data that's necessary to deliver the high-value care that our citizens deserve. I'll turn to my colleague, Lottie Derby, to complete our recommendations.
So we're going to switch gears a little bit and talk about the importance of supporting learners and clinicians. With up to 50% of nurses and physicians suffering substantial symptoms of burnout, about the same amount of medical students experiencing similar symptoms, combined with up to a third of our medical students and residents suffering from substantial degrees of depressive symptoms, the committee thought it important to also include a goal related to supporting those who are suffering recover. And reducing stigma and eliminating barriers to help seeking is a critical step in this direction and vital to improving the professional and personal well-being of clinicians and learners. So as we think specifically about our recommendations, some organizations today require clinicians to reveal past or current diagnosis or treatment for emotional or mental health conditions, despite no evidence that having such a past or current diagnosis or treatment in any way places patients at risk for lower quality of care. So we are recommending as our goal that state licensing boards, health system credentialing bodies, disability insurance carriers, malpractice insurance carriers minimize collection of clinicians' personal health information by either not asking about their personal health or only inquiring about current impairment. And this should also be done in conjunction with being transparent about how they use clinicians' personal health data in a way that is supportive of clinicians seeking help to improve their personal and professional well-being. Additionally, state legislative bodies should create legal protections that allow clinicians to seek and receive help and support for emotional and mental health problems without information being admissible in medical malpractice litigation suits. Doing so is also an essential strategy to removing barriers and to help healthcare professionals get relief from distress. It's also critically important to identify and remove aspects of the learning environment, the clinical environment, that prevent clinicians and learners from accessing employee assistance programs, peer support programs, coaching programs, and care from mental health providers. So healthcare profession, education institutions, healthcare organizations, and training sites should identify and address aspects of the learning environment, the institutional culture, the infrastructure and resources, and the policies that get in the way or discourage learners and other clinicians from accessing personal and professional support services. With respect to Goal 6, investing in research, we know some about prevalence, causes, consequences of burnout, particularly among physicians and some among nurses. But more information is needed, particularly about how it affects other healthcare professionals and also different demographic groups. Intervention research regarding what works to prevent and reduce burnout and also improve well-being in the clinical workplace and in the learning environment is also minimal. We need methodologically strong studies, we need dedicated funding, and we need collaboration to move clinician well-being research forward and to realize viable and sustainable solutions to professional burnout. So we recommend that federal agencies, including AHRQ, NIOSH, and HRSA, and the VA should develop a coordinated research agenda by the end of 2020 to identify the best measures of occupational stress, burnout, and workplace well-being in the healthcare environment, to determine the system factors that contribute to stress for clinicians and learners in all stages, and to test system-level recommendations or interventions. Agencies should commit funding to implement this research agenda. Additionally, we need to create opportunities for private and public partnerships to support research on clinician and learner professional well-being. These partnerships should include healthcare professional associations, foundations, payers, healthcare industry, healthcare organization, health profession education institutions, and professional liability insurers. We need a multi-pronged approach really involving all stakeholders to address research barriers. This includes having healthcare organizations prioritize clinician professional well-being, surfacing and testing new ideas, and sharing them to accelerate the pace of change. So with that, I'd like to hand off the concluding remarks to Christine Castle, who is on the phone.
Yes, I'm here. I hope everyone can hear me.
Yes, we can,
Thank you,
Chris.
Lottie. So the last slide here shows you the artwork that forms the cover of our report. And you may have been wondering throughout this presentation, what is this colorful design in the background? This is the artwork that was selected from a number of pieces that were submitted in response to a call for artists to try to represent this complex issue of burnout. These are the artist's own words here. Woven, the name of this painting, represents the intricacies, layers, and complexities of feeling burnt out while serving patients. It doesn't happen all at once, but it builds over time. The shimmering threads represent life and hope that is embedded in each provider, the spirit of serving, and the belief that you will make a difference. All of these aspects woven together are the essence of the provider. So in concluding, I just want to point out two things. These are intrinsic values and motivations of most of us who go into the healthcare professions. We value our professional competence and our professional values of putting patients first. The many external factors that you've just heard about often unintentionally erode these values and create barriers to doing the right thing. And this creates real moral distress. These intrinsic values and motivations of our clinicians are a precious national resource for our health systems, and most importantly, for our patients. And then lastly, because the recommendations and the systems approach that we describe is so complex, it might be too easy for everyone to think it's someone else's problem. Nothing could be farther from the truth. Everyone is necessary to solve this problem. Leadership is essential at every level, and the very complexity should not stand in the way of a shared responsibility to address this vitally important reality. And with that, I'm going to thank you and turn this over to Stephanie Maselli.
Thank you all so much for your presentation, and we'll now open it up for your questions. So as you'll see, there is a microphone on both sides of the room. And again, if you're here with us, please go to those aisle mics to ask a question. And those watching the webcast should send in your questions to supportingclinicianwellbeing@nas.edu. And whether you're in the room with us or online, please identify yourself and your affiliation when you're asking a question. Thank you. Start over here.
Hi, I don't know if it should be a beginning or an ending. I'm actually wanted to make you all aware of a resource that's come out of the Philadelphia area. It's a film, portrait of professional caregivers, their passion, their pain. I don't know if anyone here has been in a setting where that's been shown, but it's been shown cross-country screenings. I have cards for anyone who might be interested, but it's a documentary that was done by Phil Kumper and Rodney Wittenberg, interviewing caregivers of multiple backgrounds, some physicians, some nurses, some teachers, some law enforcement, and it is artistically and beautifully done documentary of burnout, and there is a legislative initiative in progress in the City of Philadelphia City Council on secondary traumatic stress. So I just wanted to make you all aware of that. If you would like, can put the card somewhere.
Yeah, thank you very much for calling attention to that resource. I think as our presentation highlighted, it is really important for all of us to figure out how we can address burnout and its consequences, and really think about what are elements of those systems that really can make a difference. So I think that's what Chris Castle was saying in her concluding remark. We all have a stake into figuring out how to solve that problem in a systematic manner.
I'll take your question over here.
Hi, Siddharth Shah, Greenleaf Integrative. I had a question about any opportunities you had for comparisons with other systems of other nations that have comparability to the type of goals and objectives and technology that we use here. I know there's no apples to apples to that, but since it's a systems, your consensus is on how our system can change. Is there evidence that other systems are more salubrious to clinician well-being and preventative of burnout?
So our analysis of the literature and the evidence and the input and information that we receive was primarily focused on what happens in the U.S. Context. We called on studies in other countries, especially in areas where there was really little evidence and data. I remember a few studies that we looked at, for instance, pharmacists or dentists in other countries. But our primary focus was really looking at the evidence in the U.S. The other part of your question has to do with what I think you're calling attention to, interventions or ways that we can better organize systems. to prevent or mitigate burnout. And maybe I call on some of my other colleagues. Maybe Lodi, you want to address that. But before you do, Lodi, I just wanted to mention one particular study that we looked at. And again, it's one small element of the system, but it's a very interesting international comparison looking at the extent of documentation that we're asking our clinicians to do. That study compared the requirements or the expectations for documentation in the U.S. With what happens in many other countries. I don't remember all the details of the study. It's cited in our report. But the data is actually pretty amazing, showing that the expectations or the requirements for documentation and time spent on those activities was much higher in the U.S. So then you start wondering, what is it about going beyond the technology and time spent on using health information technologies? What is it about maybe the healthcare organization or the external environment that kind of puts those, trickle down those demands on the clinician? That particular study did not look at burnout, I just want to specify, but it looked at one of the contributing factors that then we highlighted. Lodi, I don't know if you want to address that issue of interventions around the world. That's a big question.
Yeah, thank you. So really, it's a great question. Are there sort of lessons we can learn also from other healthcare systems? And unfortunately, we have very little research to go from in terms of looking at system-based solutions. There's only been about 15 randomized control studies and a handful of cohort studies looking at interventions for physician well-being. And there's little doubt that factors related to clinician burnout are really global. And we just don't have, and it's certainly outside the scope of the report in terms of really looking at prevalence across the United States, or across the world, but certainly we have a sense that it's not a U.S.-centric phenomenon. It's also not a physician-centric phenomenon. We really see it in all of the healthcare professionals. And the drivers are very similar. It's driven largely by work hours, as well as practice inefficiencies and other components within different levels of the system. And as you just think about different healthcare systems and different environments across the world, there are different expectations for who does what and how many hours you work. So potentially some focus areas for interventions are really to think about how can we optimize the work environment so everyone is doing their work at the type of the licensure, and what are the different system levels that we can focus our intervention research on.
I was going to simply add to a comment that this issue is pretty pervasive internationally. I do know this is a problem in Canada, problem in the United Kingdom, problem in China, and I think this is very common and is reflective of a rapidly changing environment where, our clinicians who are committed to providing best compassionate care have to work under very difficult circumstances everywhere. So they're not exactly the same in every country, but I think the overall forces are very comparable. I think what's unique about this report, in my opinion, is that it really brings together all the various pieces, not just one, and recognizes a system issue that needs to be changed. When you look at the number of recommendations here, certainly reminds me of, as we said, to As Human, where you need a real transformation in the way we do things. And perhaps each country can adopt many of the principles and contextualize in some of the unique aspects of different countries. But this is clearly an international problem. And United Kingdom's already, NHS has taken this on, and they've actually done a number of studies, initiative, as is Canada, but perhaps not to the level that I see this study has looked at a more comprehensive and evidence-based. I mean, you look at 4,000 studies they looked at, I think that's what the strength is. And also building on our strength of our organization, looking on how systems change. I think this is a phenomenal report. Thank you.
Thank you, Dr. Zhao. If I can maybe add one remark. The focus of the study was really on clinicians, and we're thinking about clinicians in a very broad way of all healthcare professionals that participate in patient care. And because of that, I think it might make things a little bit more complex, but I think it also makes solutions much more interesting and potentially a lot more powerful. If you can think about clinicians coming together, for instance, in effective and efficient teams, that may help all clinicians, not just one group. And so that interprofessional dimension of our report is really important. I think that was one question.
Yes, we'll take a question from
I'm William One from the Washington Post. It's a fascinating study. I wondered if you could talk a little bit more about the barriers to seeking help, like where things stand with state licensing, and also beyond just the licensing questions, like at what points are there barriers to clinicians seeking help? Like where do you see those kind of gaps?
So thank you. So actually one of our specific goals relates to your question, and this is goal 5 that Lodi Derby talked about. Lodi, do you want to add a few things? Yeah. Thanks.
Yeah, I certainly can add a few things. So you highlighted the issue with the medical licensing board. So one of the studies that we reference in the report has to do with looking at initial as well as renewal medical license application questionnaires. So every state has their own application form that you have to fill out when you move to a state, for example, as a physician, and then every 1 to 2 years you have to complete the form again. And many of those forms, unfortunately, have questions on there, such as, have you ever seen a psychotherapist? Have you ever been diagnosed with seasonal affective depressive disorder? Are you currently taking any medications for an emotional and mental health problem? And if you sort of check the yes button to that, it can sort of set off a cascade of events that includes revealing your personal health information in a public forum that could include putting you at risk for needing to see a counselor who's not your own mental health provider and sort of having an assessment as to your competency. And those sorts of questions actually go against recommendations from the American Psychological Association as well as from the American Medical Association and even the Federation of State Medical Boards, which is an umbrella organization for all of the state medical license application boards. So it's really a big issue. It's one of the reasons why healthcare professionals are reluctant to seek care, is they know that if they seek care, it can help them get relief, it can help them get better. But on the other hand, it could potentially set off a series of dominoes that could put their very livelihood at risk. And that's just one example. These sorts of questions can also appear on medical malpractice insurance forms, on hospital credentialing forms. So it's really something that we need to look at. Obviously, there's a lot of other barriers to care, such as not having enough mental health care providers in your community. Not being able to reliably self-assess your level of distress is another piece of it. Everybody is a little tired, gets a little sad, feels a little burnt out, but when are you sort of at that point where your degree of professional distress or your degree of personal distress is putting you at risk or putting your patients at risk? And that self-assessment piece can be difficult even for clinicians to do. So there's both this sort of self-awareness, there's the reluctance to seek care, and then if you want care, you might have difficulty finding it, right? So there's really levels of barriers at multiple different areas. But with so many of our colleagues suffering and so many of our trainees suffering, this is certainly a piece of the puzzle that we all need to work on together.
I was just going to add one comment about another barrier that's not so much around the technical aspects of licensure or getting insurance, but it's one of the reasons we thought about it in a broad way, is that there are also cultural barriers to people seeking care. There's a sense in medicine that clinicians of all types, it's not in vogue, it's not sort of readily accepted by your peers when you raise your hand to seek help. One of the studies we reviewed was, even though we know that there's some pressures around residents and hours, when you ask residents about whether or not they want to work less hours, often the answer comes back as not as clear as what the observations would say, and part of that appears to be related to this cultural barrier to raising your hand and saying that you need help in that environment. there are also studies that talk about the role of leadership in those institutions. What is the culture that's set in those institutions that looks at burnout, stress, and this imbalance of resources to demands? And so I just wanted to add that as a coda, that there's another wrapper around that as well.
And I'd like to add to Lottie's comments that the same is true from the American Psychological Association has really developed some nice guidelines about how this should be done, but only a proportion of the states have implemented for nursing, just like medicine. And so nursing is also faced with the variation across the country as to what gets reported, and it sets off some of the same cascades that Lottie described for medicine. So it was disappointing to see that we do have some established guidelines around that, but state licensure is the thing that blocks it in implementation, because all that is actually, the regulations are set by the states.
It looks like we have a few questions from the web, so I want to make sure we get to those as well.
Yes, thanks, Stephanie. We have several web questions. I'm going to read out two right now.
Sure.
So this first question is from James Berry, who is from West Virginia University. He asks, based on the available evidence, what have been the most effective strategies to incentivize executive and board leadership to address the barriers cited? And then another question is from Sarah Chuyik at, scrolling down, at Mercer University School of Medicine. She asks, what are the steps to implementing a wellness campaign at a residency training institution? What campaign projects have been shown to be most successful?
Okay, thank you. So the first question was about leadership and really how to help leadership at all levels of healthcare organizations to engage in addressing burnout. So our Goal 1 has a number of recommendations that talk about the importance of leadership, including governing boards. The recommendation talks about how governing boards really have an important role to play to ask healthcare leaders to explain what is it that they are doing, what are they doing in terms of assessing burnout and its contributing factors, as well as what is it that healthcare organizations are doing in terms of interventions, and reporting that information back to the governing boards. So this is one aspect of leadership that we talk about in Goal 1, in particular on improving the work environment. The other part of leadership has to do with really commitment and engagement. The recommendations include we're hoping that healthcare organizations, or we recommend that healthcare organizations designate someone at a pretty high level within the organization that would be responsible for clinician burnout across the organization and across the different clinician groups, and ensuring that individual is not just one individual, but has the team and the resources and the infrastructure and the commitment, the engagement of top leadership to actually implement interventions that are going to improve clinician burnout. The second question was about wellness campaigns for resident programs. Is that it? So the issue of how do we address burnout of our learners, including residents, fellows, and students, was really part of goal number 2. And Lynn, I don't know if you want to maybe make a few comments about what are some of the key pieces of goal 2.
Again, more research has been done in medical schools than it has in other health professions and environments. And there's some limited work with looking at curriculum redesign and decreasing the total amount of contact time so that the stress on students is less. looking at different grading programs. In fact, even though it's only been looked at in a few medical schools, there's some positive results from looking at pass-fail models instead of letter grade models, and particularly in the first two, or the so-called preclinical years of medical school. Implementation of wellness programs, which need to be elective and not mandatory. The results show them that when they're mandatory, they're less effective than when they're elective, and really even better access to, as Lottie indicated, better access to mental health care professionals. You can look across the country on university campuses. The prevalence of mental health issues is increased dramatically. Universities have put more resources in place to address mental health issues for students at all levels, but there's still not enough resources there to meet the demand in terms of the issues that learners are having at all levels.
Thank you.
Can I just make one quick comment about the incentives? I think one of the take-home points that we as a committee would like to put forward, and this is to the question of why should executives and board members care. We think that if you are armed with the fact that a third to a half of all clinicians are showing signs of burnout, and that burnout again leads to poor health care for individuals who your institutions have as their charge to care for, that trickle-down effect is enough for you to raise your eyes and say, what is it that we can do? And what we've tried to do is to sort of outline an approach from that. But we think that those linkages should be incentives and motivation for boards and leaders more broadly to act on the problem.
I'll take a question from over here.
Thank you. Nancy Sajati with Life Quality by Design. My question is really about taking the systems approach and expanding that concept to say, and asking whether you've looked at all the effect of the conditioning that goes into the physician from elementary school. We're talking now about all-day pre-K. We have pressure on the kids that has been mounting, and this process selects in the end, especially in medicine, for people who are very successful in that environment. And so some of what you're describing as interventions in medical school are really an ambitious attempt to undo what has just been put in for the last 15 years. So I just wonder if you've kind of tried to look at the system that broadly.
As one of the systems thinker on the committee, I appreciate your question to challenge us to think about system. The scope of our approach was really looking at what happens with the learners, and then as they transition into the clinical work environment. And what is really interesting, and our report talks about some of that data, is in particular among learners and comparing clinical learners, and if I remember correctly, that study was done among medical students or medical residents. They are at higher risk for burnout as compared to other students. And, you know, I'm in an engineering faculty, and I think about my own engineering students. And so it was really, in some way, scary to look at some of these data that when the students that are on clinical track are compared to other comparable students, that they tend, the one on the clinical track tend to report higher levels of burnout. But then you see also those high level of burnout continuing when they move into the work environment. I don't know, Lodi, do you want to? Yeah, go ahead.
Yeah, I can certainly make some comments, particularly as a mother of 3 kids. I see them in this pressure cooker environment. But what we have found in the research that was reviewed by the committee is that at least at matriculation, so when medical students start medical school, they have better mental health profiles actually than other U.S. college graduates. So they have less depression, they have less burnout, they have better quality of life across multiple different domains. So that is somewhere it's against that concept that perhaps, you know, it's the system also before medical school that's contributing. So at least at matriculation, we have some amount of evidence that the substrate that we're starting with is actually quite good. And then as people go through medical training, we see more higher prevalence of burnout, higher prevalence of depression in both medical students and residents in comparison to U.S. college graduates of same age. Once out in practice, physicians have a higher risk for burnout than other U.S. healthcare workers, even after you control for work hours and a variety of other factors. Physicians do not appear to have a higher risk of depression relative to other individuals in the U.S. population. So it does change a bit throughout the course of training and into career. We also found from our extensive review of the literature that it is really this imbalance between job demands and job resources mitigated by some individual factors that ultimately sort of determine how workplace stress is impacting the risk for professional burnout. So, of course, individual coping strategies do play a role. The committee really puts forward this concept of it's a shared responsibility with really everybody in the system, which obviously includes the healthcare professionals themselves as well.
I'll take another web question.
Thank you. This is from Christina De Rosa, who is a PhD student in nursing at SUNY Buffalo. She says, I know that your research focused on recommendations for systems change, but I'm wondering if you might have recommendations about influences that individual clinicians can have on both influencing the system changes and their own well-being, especially when working in environments that are not supportive.
That's a great question. So part of the guidelines for well-being systems that we talked about earlier are related to implementation. How do you go about implementing well-being systems that really target those job demands resources and systematically address clinician burnout? And part of the implementation has to do with engaging the clinicians themselves, as well as potentially patients. That human-centered design approach is very much anchored in participatory approach where people who are going to work in those systems need to have a say and a role in figuring out how to redesign them. So we very much think that the systems approach actually encourages the participation of the clinicians as well as all kinds of other stakeholders. I don't know, Sharon, would you like to add?
Sure. I'll make one comment that we did find evidence that there were some cultures where we saw a higher engagement in involvement in decision making, where individuals were actually at the table that helped guide the organization's decisions around making the culture healthier. Had a lower occurrence of burnout. So there's in our report there's some reporting of those kind of situations. So I would say get involved.
And it looks like we have time for one more question before we get to the close of our program.
Thank you, and I think it might be slightly connected to the previous question. I'm Jennifer Sweeney with X4 Health. I'm a consumer advocate by background, and I have also designed a relational intervention between clinicians and patients called The Third Conversation. The goal is to bring clinicians and patients together to talk about their respective experiences in the healthcare system. One of the goals is to mitigate clinician burnout. And I'm curious about the role of patients when it comes to clinician burnout. I see here that there are patient factors that contribute to clinician burnout. I wonder if you could elaborate on that a little bit more. And then I'm also curious the degree to which you think patients can help mitigate the issue of clinician burnout. Thank you.
So our report is really anchored in the premise that clinician burnout affects all involved, clinicians and patients. And again, we're using patients, caregivers, family members, and so on. The idea of taking that systems approach means that the people who are part of that frontline care delivery, the care team, where the interactions between clinicians and different members of the clinician team, the physicians, nurses, and other clinicians, as well as patients and caregivers, that care team is a really important unit where those interactions occur. And so how do you design that unit? And then how do you design multiple units, which is the healthcare organizations, and what does the external environment can contribute. So if you think about it just as an example at the smallest level of a physician and a nurse interacting with a patient during your annual visit to your primary care clinic. There are a lot of things in that system when you start looking at it in terms of the physical environment. How do they talk to each other? What is the role of the technology? Can you figure out how to use the technology to support that communication between clinicians and patients instead of having the technology, being the block in between or distraction for the clinician. So if you think about designing such a system, and again, this is just one example, we recommend that the people who have a stake in that system, including patients, have a role to play. And so designing better systems for clinicians should also have a positive impact on patients. And again, we need to think about how do we design good systems that are positive learning environment, positive working environment, but also systems that support engagement and participation of patients and the quality and safety of care that we provide. So we very much support and recommend actually the involvement and engagement of patients in the different recommendations that we highlighted in the report. So thank you very much for your question.
Thank you all for submitting questions and for the discussion. So now I'd like to invite Daryl Kirch, President Emeritus of the Association of American Medical Colleges and co-chair of the National Academy of Medicine's Action Collaborative on Clinician Wellbeing and Resilience, who will provide closing remarks. Dr. Kirch has been instrumental in the development and the operations of the Action Collaborative, and he was one of the driving forces behind this report.
This has been a great day for me personally. I have to thank that long list. I don't know if you noticed it. There were over 31 organizations that actually sponsored this report. And I think it's a reflection of how broad the awareness is of this problem, that so many different organizations step forward to underwrite the work of the committee. And thanks to you, Dr. Carrion and Dr. Castle on the line, and all the members of the committee for truly an elegant piece of work. It's a roadmap for where we need to go, but a roadmap isn't much use if you don't take the journey. People alluded to crossing the quality chasm and to err is human, those earlier reports, but that started us all on a journey around patient safety and quality that we're all still on, but where we've seen real results. I think as recently as 5, 6, 7 years ago, we were generally in a state of denial about this problem. I want to credit Victor Zhao, who as president of the Academy took on the issue with the Action Collaborative. Not only did he take it on, he has chaired the effort. And I've been privileged with Tom Naska to co-chair it with him. And we hope to carry this work forward, but with a growing group of organizations nationally. I have to say, I think the most brilliant aspect of the report is the systems framework. Because we historically, I think, when clinicians have been burned out, have felt that it's somehow their fault or that the solution is to fix them rather than acknowledging the underlying systems problems. And the report does such a beautiful job of showing that funnel of the environment, the organization, the front line of care, and how those issues, the imbalance, affect the individual. In terms of affecting the individuals, the report also makes it clear that burnout is a workplace condition. The emotional exhaustion, the depersonalization, the loss of meaning. But as a clinician, I know it's a very short path from the stress of burnout as a workplace condition and much more severe problems, anxiety disorders, depression, substance abuse and suicidality. And that involves a real human toll. I mean, when those things happen, the vibrant colors in the artwork that graces the cover all turn gray. I know that from personal experience, having become burned out and then depressed as a first-year medical student, and being rescued by an understanding student affairs dean. But I could have easily been one of the individuals who left the profession feeling stigmatized and ashamed. This is a call to action for all of us. I think you've given us, as I said, a beautiful roadmap for moving forward. I thank you again, and I thank all of you, both here in the room and on the web, for participating. It's been a great day. Thank you.
Thank you, Dr. Kirch, and that will conclude today's event on our new report. As a reminder, you can download the report and related materials at nam.edu/clinician wellbeing study. And yes, the slides and the recording will be available there as well. I'd like to offer a special thanks to the committee members who joined us today. As you heard, they were representing the diverse experience of the entire committee that wrote the report. And thank you again for joining us today. Have a great rest of your day.